We just had a discussion as to whether heart failure with mid-range ejection fraction could be considered as a separate entity, or it is just a transit diagnosis coming from worse condition to improved condition, or coming from improved condition to the worse conditions. To talk on all these issues, we have with us Dr. Nitin Burkule, who will be talking on defining HF-MRF, its prognosis and its variant through ECHO. Dr. Burkule, please.
Yeah. Thank you, respected chairpersons. Now let me talk about this HF-MR-EF, which is earlier called as mid-range EF, and then it transited to mildly reduced EF. And let me convince you, should we be sticking with this term and this current definition? And I'm going to give both the sides for and against that. Or let me put an analogy. Have you seen the map of Korean peninsula? You have North Korea, you have got South Korea, and in between you have got a 3 to 4 kilometer wide zone. Okay, that is called as DMZ, that is demilitarized zone. So, and the quality of life improves from north to south. So, I would say Dr. J.C. Mon talked about North Korea and Dr. Shantanu talked about South Korea. I am going to talk about DMZ. So, heart failure definition, as we know, is the clinical syndrome with the symptoms and signs, and it has to be caused by some structural or functional cardiac abnormality, and that has to be corroborated with the either elevated natriuretic peptides, or you show some objective evidence of pulmonary or systemic congestion. That's the universal definition that all of us know. Then I remember from say, somewhere 92, 90 or 95 or 93, 96 during our cardiology residency, and then thereafter post-residency and throughout the clinical life, the term has evolved. First it was called as hypertensive hypertrophic cardiomyopathy of elderly who are going in heart failure, because people could not make out how these people with normal EF are going into heart failure. Then came the concept of diastolic heart failure, but the problem was that some of the almost 25% of the heart failure patients do not show significant higher grades of diastolic dysfunction, or other way around, you have got grade 3 diastolic dysfunction patients and they are going for the treks. So this was discarded. Then came the question of heart failure with normal systolic function. But people realized that the EF was normal, but their GLS was dropping, so you can't say it is normal systolic function. Then came the concept of heart failure with normal ejection fraction. But then we knew what is the normal. We really don't know, because it changes with the gender and ethnicity also. So they finally settled down to PEP. And how this, so the thing is how this thing came into existence, because the earlier trials of neurohumeral blocking, which was the first great breakthrough, the most of the patients into those trials were less than 40%, because they wanted that real, the patients with heart failure and a definite reduced ejection fraction. So people didn't know what happens above 40% of EF. So it was the CHARM group that first coined this term, that anyone above 40% will call them preserved ejection fraction, and then it stuck with it. So thereafter, obviously, these trials of DAPA and the empagliflozins also used this 40% cutoff. And then this iPreserve, the failed trials of iPreserve and TopCats use 45% as their cutoff. And now the ESC and SEC definition are putting it an arbitrarily 50% and above as a heart failure with preserved ejection fraction. So let me challenge this. That means this is an area of 41 to 49, and we are calling them as a mid-range EF. Can EF, the echo, be so accurate to pick up this narrow band of EF? I don't think so. Let us look at the EF by reproducibility by echocardiography. The inter-observer variability in various studies is anywhere from 8 to 21%. Your intra-observer variability itself can go from 60 to 13%. So it is virtually impossible that 41 to 49, this bandwidth you are going to pick up. That is first thing. So we are fooling ourselves. Secondly, if you look at the TopCat trial, the core laboratory reclassified the EF in 20% of the cases. And forget about this was not only EF, but I'll tell you in the Stitch trial, even the cardiac MRI EF in almost 1/3 of the patient was reclassified by the core lab. So that means you are wrong in at least 1 in 5 cases. Then tell me how many of you have reported an EF of 43%, 47%? No way. all of us round it off to the nearest 5 or 0. Okay, we call it 45 or 50, or we'll call it 40 or 35. Okay, so I think this narrow band is just people sitting around the table and creating the guidelines, and they tell you that this is a mid-range EF. So the normal distribution of EF, how this 50% came? Because actually the normal distribution changes with the age, with the gender, and also ethnicity. That is clearly known now with the worldwide data available in WISE study. So I think, so that's the challenge. Then what this narrow boundary of DMZ is, that demilitarized zone is, okay, there are people who are HEPs, and then they deteriorate and they cross this line into lower EF, okay? And then you have got patients of reduced EF who on the optimal medical therapy and CRTs go back to recovery. So they are just crossing this zone. And this DMZ, we are catching it and calling it as a mid-range EF or mild reduced EF. So what is the profile of these patients? Now these patients account for 25% of the heart failure patients, and they are more males, okay, unlike PEPs where more females are there. They are younger than the patients of HEPP, because you know the PEPs people are generally older and the REF people are generally younger, and these people are in between. Then they are more likely to have CAD. Almost half of them can have CAD, just like REF PEP people. While your PEF people actually much lesser incidence of CAD, then they are less likely to have ejection, atrial fibrillation. And unlike PEF patients, they are less likely to have multiple comorbidities like hypertension and CKD. So this actually profile goes little closer to the REF people, okay? And they have got less rise in BNP unlike REF people. So if we put it all together like this, now this is a very interesting Nature's Review in Cardiology paper which entirely discussed this, this mid-range EF. And you can see that this is the profile of the PEFs as far as their comorbidities are concerned and their treatment effect can be concerned, and this is the REF profile. And you have got something in between, this craggy line in between. So it has got probably slightly more closer to the REFs, okay, but their treatment effect is slightly closer to the PEPs. And then what about their mortality or CV outcomes? So I'm going to show you the chart. Remember, the yellow bars will be mid-range and the red bars are the PEPs, okay? I'm still calling it mid-range. I have still not gone to mildly reduced EF. So these are the mid-range. So just look at the yellow bars and the red bars. And on the left side are all the clinical registries, like getting with the guidelines and all those things. And on the right side are all the trials. And you can show that the mortality of the MREFs, that is the mid-range, and the PEPs is very close. So that means these are having a profile of a REF, but the outcome is like PEPs. Okay, that kind of a thing it is. Then now with the current guidelines, the guidelines talk about the trajectory of EF also, because people have realized that EF is a quicksand. So now we have the initial classification that the first echo at diagnosis you do, and you call it as REF, less than 40, above 50 you call PEP. But each one of them on treatment changes its class. So for the mid-range, he can either deteriorate, he can be the same, or he can improve. Okay, so that is the fit as per the trajectory is concerned. And so that means what happens is the mid-range ones can have 4 different things. That means the first time you diagnose, you call it mid-range. Then the thing is he gets unchanged even on the therapy. Then if he gets deteriorated, he becomes REF, or he gets improved and goes into the PEF category. So that is how the population is moving across this narrow band. And we say that we have got so much of accuracy to pick them between 41 to 49. So I mean, we are fooling ourselves. So let us go ahead. If we look at the EF trajectory of these patients, if this is a baseline mid-range EF, then almost you can say 1/4 of them, the EF improves to PEP. And almost 40% remain in the same, and the rest go and deteriorate to the REF despite the optimal medical therapy. And this is nationwide. This is a Scandinavian study, or the entire nationwide study of looking at the mid-range EFs. And if you look at the trajectory, it is very obvious that those who have increased EF, they have better survival, and those with a very decreased ones are going to have very poor survival, which is a no-brainer. But it has been proved by this nationwide study. So you can go to the original article by Saveris. So this is how it is. Then what about the diagnosis of it? Now, I think looking at the way that we may over or under-diagnose, I think ACC has put quite a strict criteria that it is not only the EF by which you diagnose the mid-range EFs or the preserved EFs, but it is important that you show an evidence of increased filling pressure, which is not required when they are having an EF less than 40%. So mid-range, you have to show an evidence of increased filling pressures either at rest or with exercise, either non-invasively like with BNPs and the echo diastolic parameters, especially the LA volumes, E by E primes and the mass and or the isolated E primes, or you do a cath. And the cath also can be at rest or with the supine bicycle exercise. But it's important that you show rising filling pressures. Don't depend on diastolic function, because the diastolic function has a very poor correlation to the heart failure syndrome. So that's how it is. Now let us look at the trials data, and when you put the both Paradigm and Paragon together, you can realize the hazards ratio are actually crossing way high, especially the female. So in that trial, the post-analysis showed that 57% was their median, and up to 57 there was a benefit. But female, it went to 60% plus. So if you can even the 95% confidence limit is also crossing at 55%. Okay, so that means this mid-range EF band is benefiting with ARNIs, though the treatment effect is definitely lesser than the refs. So also the data of the CHARM, looking at the candesartan, also does the same way. You can see the 95% confidence limit. The upper one is also crossing at 50 or 55% depending on the gender. So also for the MRAs, if you take the top cats of only American ones and remove the Russian data, and if the same thing is for ARNI as we had seen here, but and putting them all together for CV death and the first heart failure hospitalization. So also if you go back to our old studies of digitalis also, you can see that the hazards ratio, even the 95% is crossing somewhere above at 45 to 45%. So the thing is, that means they are getting benefited. So should we be really calling them as mid-range? I think probably they are mildly reduced. I think it is better that we start calling them as mildly reduced as the guidelines say. And now we are at least class 2B indications for the older neurohumoral blocking drugs, and the SGLT2 has advanced to class 2A indications. So that means this mid-range one, we can reclassify them as mildly reduced EF, so they are at least reduced EF because they benefit from all these traditional drugs, and more importantly is that they are behaving similar to refs. And only thing is the treatment effect, that amplification of treatment effect is lesser than the refs, and their mortality is like PEPs rather than the refs. That's the only thing. So you can say that there are definitely mildly reduced kind of ref population only. Okay, so why confuse ourselves? The second thing is that I think Dr. Lam had a very good point. She says why we are discussing this narrow bandwidth. So let us change it over. Let this mid-range EF, what we are calling, or mildly reduced EF, just expand them and let it be 55%, up to 55% for the men, and let it make it 60% for the women. So you now go from a very large bandwidth of almost 20% of bandwidth, which you will be able to pick up by the echo. And why we still calling them as mildly reduced EF? Because we don't know whether you can put a CRT in that, whether we can do a ICD in that. We don't have, because all those are having a cutoff of 35%. But at least expand this to 55 for the men and at least 60% for the females. Then you have to further phenotype this by GLS, because you want to pick up the amyloids. Look at the LG and ECVs to pick up the amyloids. Look at the multiple biomarkers, proteomics. Look whether they are the hypertrophic cardiomyopathies who are going into burnout phase. And probably there is a role of genotyping them, because those with the lamin A and C protein mutations have a high incidence of sudden cardiac death even in that 40 to 50% range, and they never classify for that 35% cutoff for getting an ICD. And finally, you should pick up sarcoids because you treat them and their EF improves, and obviously you should rule out ischemic heart disease. But let me tell you to my last slide, more provocative thing that we were talking, you bring to 55 and bring to 60. But there is a difference even between 50 to 60%, more than 60%. This is a very interesting study, a German group. They looked at all those patients between 50 to 60% and above 60%, and they actually did the myocardial biopsy. Can you beat it? In these patients, they did myocardial biopsy. I think, how did they get the IRB approval? I didn't know. But they also had the pressure volume loops for this. And you can see that patients between 50 to 60% still had a low contractility. If you look at the end systolic pressure volume relationship, they had larger volumes. Their biopsy showed more fibrosis. Their extracellular volume was expanded. So they were behaving more, even at between 50 to 60, they were behaving like reps. While those who were above 60%, they had a good contractility as end systolic pressure volume relationship, but they had a compromised diastolic function. If you look at the LV end diastolic pressure volume relationship, that they had a compromised preload, and there was also, and they still had a preserved they had still preserved the contractility, and their fibrosis was less, but they were more hypertensive and hypercontractiles. So that means this is a moving target, and even in this group also probably we can keep on pushing the upper limit above and further phenotype this population. And I think we should not just go blindly for this current 41 to 49%, because I know this is absolutely inaccurate, and I think we have to keep our mind open, and this particular patients in so-called DMZ, I think we should push them more towards North Korea rather than South Korea. Thank you.
Thank you, Dr. Burkule. I think there is a nice depiction regarding this mid-range ejection fraction, and the dispute that has been arised, I think that is valid in 2022, because even after acceptance of this 2016 ESC guideline has accepted this mid-range ejection fraction, the dispute continues, because it is not that absolute value of ejection fraction that is getting reflected over the clinical entity. Clinical syndrome is not well correlated with ejection fraction all the time, and particularly sudden cardiac death. We'll discuss that after end of the second speech. Accepting the term that heart failure with mid-range ejection fraction, we are accepting that term till now, and I'm inviting Dr. Subra Banerjee to speak on ARNI in treatment of heart failure with mid-range ejection fraction. After completion of that, we will discuss some disputes that is still there. Few points we will discuss. Particularly sudden cardiac death is not well elaborated in this group. I am here for last 1 hour. I have heard with preserved ejection fraction, with reduced ejection fraction, but there is no correlation regarding sudden cardiac death. And there are some studies also that shows that patient improved from 20 to 35 or 45, the sudden cardiac death ratio does not change. Dr. Banerjee, please.